Hello, exchangers of the gas. Welcome to the Gas Exchange podcast, where we talk about respiratory critical care. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. This podcast is part of our efforts at Inspire Respiratory Critical Care, where we provide expert panel discussions, pearls, virtual classroom lectures, and other philanthropic initiatives. You can find our podcasts on YouTube, Spotify, and Apple Podcasts. On our website, www.inspire-rt.com, you can find links to our past recordings and many other resources. My name is Keith Lamb, and I'm the host. I'd like to welcome my co-host, Thomas Perino,
Hi there.
and today's very special guest, Dr. Tyler Weiss.
Hello, Tyler.
How's it
Hello,
going,
Tyler.
Keith? Nice to be
Dr.
here.
Weiss is a highly respected respiratory therapist, educator, researcher, and a very close colleague and friend of ours. Welcome, Tyler. Can you tell us a little bit about yourself?
Sure. Yeah. Thanks for having me. So, as mentioned, I'm Tyler Weiss. I am the Director of Clinical Education and Assistant Professor at Rush University's Respiratory Care program. So, my my interest here, what we're probably going to talk about is, my whole doctoral research, which I defended last year. So I'm about 1 year officially, Dr. Weiss. But it was all about prone positioning and ultrasound. And then it's kind of my interest in ultrasound has started to expand in the hands of the RT. So I would like to talk with you guys a little bit about that.
Great. Yeah. So, Tyler, you're an expert in a lot of things respiratory critical care. But when I think of Tyler, and we talk quite often about these things, but when I think of Tyler, I think of prone positioning.
Yeah.
And I think of ultrasound, and even more specific to ultrasound, I think of how you've taken on this sort of idea and teaching of the use of ultrasound by respiratory therapists. So, point of care ultrasound by respiratory therapists. Why don't you start us out by talking a little bit about that?
Yeah. So, I think we're in the days where, ultrasound is in pretty much everyone's ICU. I think that's pretty safe to say. If you just think about its use, it's no radiation. It's readily available. It's, to be honest, pretty easy to use. When I was taught how to use it, when I was getting trained myself to execute my doctoral work, it was really, Dr. Sarah Mirza was the one who trained me. And she would go and ultrasound some patients in the ICU, and she would give me a call and be like, okay, go ultrasound, 1051 and 1054 and report back to me what you found. And pretty soon after I would start doing that, I was hitting the findings. So I was shocked when I first started, doing ultrasound on the lung. Was, when Dr. Mirza first gave me the probe, said, "Okay, put the probe right here on the patient's chest." I put it there. I was like, "Okay, now what?" She goes, "That's it. Look at your image. It's there's the lung. Here's the pleural line. Here's your." I was like, "Oh my gosh, like that easy, right?" So I mean, getting the image, to be honest, is pretty easy. Then the next step is understanding what you're looking at. And I think that's honestly probably the hardest part, like your orientation, what's up, what's down, what's left, what's right. And then just looking at the artifacts that you're seeing. So, my doctoral work was really looking at, can we utilize ultrasound to predict response to prone positioning? So, we always use oxygenation, and oxygenation is still something that we already know, like whether patients do well or not with prone positioning, their oxygenation usually improves. The Proceva trial showed that, and all the other prone studies prior to that showed, yeah, everyone's oxygenation improved, but some people died still, right? So, but we still always are kind of very fixated on oxygenation. So my study was to look at other factors. Obviously we look at lung compliance. And so adding lung ultrasound in was just an added thing that I wanted to look at, pre and post. So when I think about lung ultrasound in the respiratory therapist's hands, I don't think of it as replacing, the stethoscope or replacing your patient assessment skills. It's just an added tool to help hone in. Let's be honest, auscultation can get you so far, right? Especially depending on, patient's body habitus. It's like, I can already tell you that regardless of what's going on in that patient, their lung, they're going to be pretty diminished.
Decreased.
Yeah, just diminished based off their body habitus. So, And then, again, we're relying on imaging, chest X-ray, CT. We use those all the time. CT is great. If I could have a CT for every patient, it'd be amazing. But there's logistics that go into that. So learning more about lung ultrasound, I started learning that lung ultrasound actually has a higher sensitivity in diagnosing many of these things that we're looking for: consolidation, pneumothorax, pleural effusions, than chest X-ray. So it's like, okay,
Yeah, and
well, why?
radiation's not an issue, right?
And
This is
radiation's
Mhm.
not an
one of the
issue.
main thing.
Yeah, radiation's not an issue. It's already in the ICU. We tend to have to wait for chest X-ray to come. So why not do that assessment? Sure, still get the X-ray. X-ray can tell us other things as well. But while we're waiting, when your patient's acutely in distress, why don't we do a quick assessment and see, okay, this is what I'm seeing here. So I probably already know what's going on before the chest X-ray even gets there. And there's even been studies that comparing lung ultrasound to that gold standard of chest CT, and a lot of the data shows that lung ultrasound is pretty good compared to CT. So better than chest X-ray, pretty similar. Obviously, CT's the best at identifying things, but I'll tell you, from the data that is out there, lung ultrasound is right up there with with CT. So I just think it's an underutilized tool in the respiratory therapist's hands. Physicians use it all the time. I mean, you walk around, some of our physicians, when you see them going and kind of doing their rounds in the ICU, seeing all their patients, they're pulling out the ultrasound and ultrasounding every single patient. So I don't see why can't the respiratory therapist do that? And really
Mhm.
assessing changes that are occurring. We're doing bronchial hygiene or adjusting PEEP or adjusting various ventilator settings. Why not assess them before we do them, before we prone them, compare what's it looking like after we prone them? I just did this bronchial hygiene therapy. This is what they looked like before. Here's what they look like now. Um, so I just think it's another tool in the arsenal. um, and I know we always talk about, like, how many is too many tools, right? Like, we throw everything at the RT, can't sit and do everything. We have EIT, esophageal manometry, lung ultrasound, all the other things. Like, how much is too much? But again, I think some of that comes down to too is like maybe you don't have EIT. Maybe you
Yeah, I was
don't.
gonna say, you kind of pointed out, like, every ICU has an ultrasound, so
Right.
it seems like
Yeah.
a no-brainer. And
Yeah.
really there's three, and correct me if I'm wrong, but I feel like there's three main use cases for ultrasound, not just lung, for
Yeah.
the average ICU respiratory therapist. Now, depending on your role, so I've worked in hospitals where the RTs insert art lines. So if you
Hmm.
insert art lines, you really should utilize and learn how to use ultrasound to guide arterial line placement. Some people may argue, well, no, you shouldn't need to do that. You should be good at your skill. I can tell you that ultrasound is like, once you use ultrasound to put in an arterial line, you don't want to go back.
Yeah.
Like, it
Yeah.
just makes so much of the process just simplified. Honestly, like, we've all had patients where you get called to the room because the resident may have tried 6 or 7 times to put in an art line, and now you have to put it in. And clearly they had trouble feeling the pulse and landmarking properly. Then you put the ultrasound on, you're like, oh, there's the vessel right there. Like, it's so mind blowing the first time you do it. And then the second one, of course, is lung ultrasound, which you mentioned. And then the third is is diaphragm thickening
Diaphragm.
fraction. So some people will get that confused. And we had Dr. Irene Tellius on the podcast recently. It's not out yet, but she was explaining this important fact, that if you were to order diaphragm ultrasound, most of the time someone will come and do an excursion of the diaphragm. Diaphragm
Hmm.
excursion is a very
Mhm.
common diaphragm
Yeah.
ultrasound. However, when someone's on mechanical ventilation, it's a useless tool, because if the lung is inflating, the diaphragm is moving. An excursion, the movement of the diaphragm is not what's important. It's the thickening of it, because that
Yeah.
tells you the diaphragm's contracting. And I can tell you clinically, we've utilized that to discover a patient was using complete accessory muscles to breathe. We put an EDI catheter in and got no signal. People thought the catheter was broken, but it turns out the diaphragm wasn't thickened. It wasn't contracting. So there was no signal. There
Right.
was a phrenic nerve issue, and there was no signal. Diaphragm was non-functional. So in terms of understanding the complexities of weaning a patient, there's so many avenues. Again, there's the acute monitoring with arterial line. There's lung ultrasound when quick things go wrong. Like, we're pretty good as respiratory therapists to say the words, "I think there's a pneumo."
Yeah.
But like, why not confirm it with
Why not
ultrasound?
confirm?
It's
Exactly.
just
Yeah.
as sensitive, if not more so, than a chest X-ray
Yep.
to show you that you have a pneumo. Um, and then, of course, when you're having trouble weaning patients, assessing diaphragm function these are three things that RTs are so integrated in terms of how we could utilize these tools. And yet, I 100% agree with you. It is underutilized across the board. Um, I know here in Canada, or at least in Ontario, it's a delegated skill, so we can use ultrasound. It just needs to be delegated. Like someone needs to say, yes, you can go ahead, provided you have the skills, knowledge, and judgment to perform ultrasound. They can
Yeah.
delegate you to do ultrasound. So, but it's not one of our controlled acts, so we can just. And this is one of the issues. We can't just go and grab it and do it. So for people learning it, they have to be in an institution that's willing to support that and say, okay, we want to teach you, and then give you the authority to do it through delegation acts, or through medical directive orders, et cetera.
Yeah, I think that's a good point. That's how, again, we had a physician, our Dr. Mirza was our medical director at the time. And just the pulmonary group altogether at our institution is very, pro RT and let us do what we want to do, obviously under direction. But having that, physician support to kind of
It's
help
key. It
yeah,
really is key.
one, just guide you into how do I learn how to do this? Like, can you show me how to do it? And then I can take it from there and teaching other people. You don't have to teach the whole department. Teach a couple people to be, quote unquote super users. And then on top of that, we're at our institution. You can just grab the ultrasound and play. And I often encourage the RTs just do that. I'm not telling them to take the ultrasound, try to interpret and act on what they think they see, right? I'm
Mhm.
telling them, go, if you know that your patient has a pneumothorax, it's already been confirmed, take the ultrasound and go find it. See if you can see it as a way to teach yourself how
Mhm.
to, assess for that. They have a large right pleural effusion. Go find it, right, with the ultrasound. Again, as a way of recognizing the patterns. But I'm not saying go find the pneumo and then needle decompress if needed.
Right.
So I'm saying, go and utilize it. Because with anything, it's like repetition. And that's actually when we so we published a study last year, 2 years ago, teaching respiratory therapists how to do lung ultrasound. And what we did is we had a didactic, going over all the things you can see, what it looks like. And then we had them practice on a healthy volunteer to sort of get the technique down. And then we took them to the bedside. And we took them to the bedside to actually ultrasound patients in the ICU. They would score. We taught them a scoring system, so 0 to 3, depending on the pathology that they saw. 0 being normal, 3 being completely consolidated lung, and they would score each segment that they assessed, and I would score while I'm looking, and we would look and see how well uh, our scores agreed. This was an effort to see how many ultrasound sessions does it take to be quote unquote competent.
Mhm.
Um, and then what we did is we took a break. We said, okay, now like from here on out, don't ultrasound anymore. Once we had some people that are like, okay, you're doing pretty good. Now from here, don't ultrasound. And then we're going to repeat this, in like 6 months. We repeated in 6 months. It was like starting all over from scratch.
Mm.
Yeah. Some of the recognition of uh, diseases or like the pathology, sure, they got that. But some of the stuff is just, and yeah, it's like if you don't use it, you kind of lose it. Now, once you really do it over and over and over, like I could go, if I haven't ultrasounded someone in a couple months, I could go and do it now and be just fine because I've done so many.
Yeah.
Um,
That's like me in esophageal pressure. I
yeah,
could
yeah.
go
It's like, gosh,
a
I haven't
year,
done one
2
in
years without putting a balloon in, but I
yeah,
could throw it in and do all the measurements and not even hesitate, just because, well, yeah, once you do so many, it really becomes like a language where you're like, you don't
exactly.
forget how to speak it, you know?
Yeah, but when you're first starting, okay, you've done like 10 and now you seem pretty good at, getting the image, you're scoring it appropriately, you're identifying what you're seeing, and then you don't use it for 6 months or so in the very beginning, then what we saw is quite a reduction in knowledge, but then you give them a quick refresher and boom, the knowledge went right back up. So, um, I think it's a thing of repetition. And again, I think it's just something trying to find a place I've had some institutions reach out to me. There's one in Texas. I can't remember the institution. But their educator reached out to me to see what we were doing with the lung ultrasound, because she heard I did a lot of stuff with ultrasound. And to be honest, they called and I was like, I should have been calling you. You guys are using it way more,
Mhm.
than we are right now. Like, we're sort of dabbling, trying to figure out how we want to incorporate it. And what they were doing is the physicians expected a report on the lung ultrasound every day in rounds, and it's sort of part of their initial assessment. And I think they tracked, like lung ultrasound score. So, okay, the lung ultrasound score was 18 yesterday. Now it's 12. So, okay, the late patient's improving, maybe less pulmonary edema or pneumonia is improving.
Did they have a dedicated RT for that, or was the RT responsible for that patient doing that for each one of their patients, like when they did rounds?
Yeah. So it sounded like the therapist, that was their patients, they were responsible for doing that. And that's
Wow.
always
That's a
that is
well-staffed that's a
right.
well-staffed
That's kind of
ICU,
why I was
man.
like,
Yeah.
how the heck do you? Because I mean, and again, you can do several different types of exam. You could do a abbreviated exam, which is, like 3 points
Mhm.
on each side versus like a full exam, which is 6 on each side. Uh, that 6 point, assessment, the 6 on each side, so 12 total. Uh, I'll tell you again, once you do a lot of them, you can do that pretty quick. Because I
Yeah.
mean, again, it just takes hitting the probe. Okay, that's a 0. Okay, a 2, you know, 0,
Yeah,
1.
if you're fumbling to figure out whether or not you're between a rib or not, then obviously it's
Yes.
gonna take you longer, but
Take you a
Yep.
minute, yeah.
that's
But still,
that's something that gets you sort that out real fast, you know?
yep. Yeah. So again, the more and more as I said, like I mean, this was in the height of COVID when I was doing it. I mean, all of our patients were prone. So I had a blow up mattress in my office because I just slept there.
Mhm.
Because I
Been
had
there.
to ultrasound every sound before prone, after prone, 15 hours into the prone session, an hour after supine. I would ultrasound them 12-point exam for their first 3 sessions. I was up there, I was just busting them out because after I got so many, I could do those exams pretty quickly. But that's always the thing that comes up is like, even with our staff, I was like, so with what extra time that we don't have, do you expect me
Mhm,
to
yeah.
go and do
Well,
this?
that's why I asked that question, because 'cause I'm
Yeah.
like, a full set of rounds, and if you have 6
Yeah.
if you're 1 RT for 6 patients, that
That's a lot. It is
really
a lot.
adds I mean,
Yeah.
especially if you're not, if you haven't done hundreds of them, if
Right.
you were just taught the skill last week, your rounds are are gonna suffer.
Yeah,
Yeah.
and also
Yeah.
that department has a lot it sounds like has a lot of support from the rest of the team, right?
Yeah. Yeah. There
To
has to be.
expect the RTs to report off on ultrasound.
Yep.
Yeah, and I'm not knocking that, I think that's great,
No,
I'm
I think
just
it's a
like,
great
yeah,
No, it's
idea, yeah.
amazing.
I was just shocked 'cause I'm like, "Do they have someone dedicated to do that?" Or is it because,
Yeah.
like, that really now, at least it's once per shift, but your major set of rounds in the morning are obviously gonna take a little bit longer than the average, RT if you're also performing ultrasound. Also, I'm thinking equipment, like, they must have a lot of ultrasound units in that
Yeah. So they
ICU.
actually, what they did is they bought like the little butterfly or,
Yeah, the little plugs into your iPhone.
yeah,
Okay,
which
yeah,
really I
yeah.
think is, we have our own, but we have the one that's in the ICU. We have our own for
Yeah.
respiratory care.
When I saw that thing pop up on social media years ago, I wanted one so bad. I actually
The
looked into
butterfly.
it, and yeah,
Yeah.
you had to be a physician to purchase it. Like, you couldn't just
But
purchase it as
yeah,
an RT.
yeah,
It's
it's
like you
nice.
had to be part of an institution or like show your medical license or something.
Dang.
I was just like, damn it, I so badly want this ultrasound, but yeah, they
Yeah.
don't just sell it to random people on the internet. That's
And I
probably a
think
good thing, but
that's all
Oh.
the RT needs. You don't need the fancy one. Again, we have the fancy one for us, but uh not just because we could, so it was nice to have it. But
mhm,
um I think doing the assessment of just to see what's going on with your patient, all you need just the small one is fine.
mhm,
Now the bigger, more expensive ones, which are usually the cost of a very nice car.
Mhm.
One probe costs 12 grand. So so you're looking at 3 different probes, maybe, and then the actual device, you're pushing $60,000. So am
Mm.
I telling
yeah,
everyone to go buy a $60,000 machine? No. You can get the $1,000 machine that plugs into the iPhone or an iPad. Obviously, the fancier ones give you some different features. There's AI integrated into a lot of them, especially when looking at art. Like the one we have will actually count the amount of B lines,
mm,
for you. although I don't really use it, so I find it a little bit, I don't know if I trust it fully yet, but again, that could just
Yeah, I
be
mean, it's important to understand what you're seeing to know whether or not you agree with the
yeah,
assessment,
yep,
but it could speed up the assessment in terms
it
of like
could.
if you agree that this is coalescent versus like if it's
Yep,
a 1 versus a 2
yep,
essentially, and
exactly.
the system is like, well, this is how many, you can be like, yeah, that makes sense. Okay, yeah, this
Yep,
is definitely a 2. Especially like sometimes you're on the fence. I'm like, I'm pretty sure this is a 2, but there's some gaps here. Could this be a
yeah,
1? You move it over, it's like, oh, that looks a little bit more 1. You move it this way, it's like, oh, that's a little bit more 2.
yeah,
So again, having some AI maybe influence your decision, but not take it over entirely, I
yep,
think
e
is welcome. It certainly speeds things up.
exactly, I think that's how we are with AI altogether. It's like, there's
Mhm.
always the talk of the AI taking over, just managing the event for you. They're like,
Right.
I mean, sure, like, maybe it can notice some things, but you still need a respiratory therapist to confirm it,
Yeah,
and
we're not there yet. Like, yeah,
yeah,
every closed loop, you know,
yeah,
there was just a recent closed loop study on ASV that didn't show benefit over just a regular protocol driven management. So yeah, we're
yeah,
not there yet, but
yeah,
the opportunities there for, I mean, I I I think with AI, the thing that's going to help the most is probably with asynchrony recognition, but also we need to first understand whether or not we should even intervene with half the asynchronies we
Yeah, if we
see.
should worry about it or not.
There's
Yeah.
some that are easy to intervene, and then things like like reverse triggering, which are a little bit more challenging. The question is like, do we need to do anything about it?
yeah,
Could it be beneficial? Is it injurious?
mhm,
Is there breath stacking? Blah blah blah. Whereas
yeah.
like ineffective efforts, it's like we can usually fix. I mean, at least I can usually fix ineffective efforts or early cycling, but reverse triggering a little trickier sometimes.
Tom can fix
Um,
anything.
not anything, but yeah,
Yeah,
some
so
things.
I do know there's a few of the ultrasound devices that are out that are in the cheaper realm of ultrasounds. I mean, we're talking like 20,000 versus,
Mhm.
60,000. So cheaper.
Like full
So
machines versus pocket
they're
machines.
they're
Like,
not even full. They're not necessarily full machines, but they're machines that have like almost it looks like an iPad type size
right, like a
tablet,
tablet. Yeah.
but that has AI integrated. You can get the EF. Um, it will count B lines, things like that. So again, cheaper, still not, still a
I
large
feel like if I
capital.
had an ultrasound at home, I would just ultrasound everything.
So
I'd be
I
like,
have that
my
fancy
leg is
machine.
sore. I'm gonna ultrasound my leg. I don't know what I'm looking at, but
Yeah.
Yeah,
Oh, I got a DVT.
yeah.
Dang.
yeah.
So I do that actually, oddly enough. I
Oh,
have an
when I learned
ultrasound in the
Artline,
office.
I was scanning my Artline all the time.
Oh,
When I was
yeah.
teaching
Yeah,
staff, I'm like, I bet you can find my arterial, like I bet you can find my artery in like
yeah,
5 seconds. And they're like, really? And I'm like, yeah. And I would, yeah,
yeah,
they would
you
find
see
it.
a
I'm like,
pulsatile, there's gonna be this little
yeah, I'm
thing
like,
just
just apply a little bit of pressure and
pulsing,
look at which one is like
beating.
bounding. And they're like, oh
Yeah,
wow, it's like that's really easy. I'm like, yeah.
yeah,
So anyway, I feel like I would ultrasound myself just for fun.
yeah. Yep. To get to that whole point on, time, because I understand we're already busy as it is. So now you're
Yeah.
telling me to do something additional. I always pose the question to the RTs, like, how many times have you been asked, like repeatedly, to do aggressive bronchial hygiene on something that you're convinced, t-
Mhm.
like I could do vest until the cows come in. This is not going to fix the issue. Uh, and they're like, "Oh gosh," they're like, "I've done CPT to a pleural effusion, for like a week, and I knew it was a pleural effusion the whole time." And I was like, "Well, wouldn't it be nice if you just took a probe, you popped in, and like had the doctor come over? Hey, look, do you see this is a massive, fluid collection. It's not, atelectatic lung. Like, sure, maybe there's some atelectatic lung above it, but this is probably all due to the effusion. So instead of wasting our time doing this not necessary bronchial hygiene, perhaps we treat the root cause. Again, going back to the chest x-ray, we usually diagnose those effusions, by chest x-ray, which a recent study, I think it was like around a 75% sensitivity on chest x-ray versus like a 99% sensitivity with ultrasound. So you have like that 25% gap that you're the chest x-ray, you think it says it's there, but it's actually not. And so
No,
again, it's
you bring up a good example. Like another Another example similar to what you're saying that I've had experience with, and maybe you guys have as well, because you've all put esophageal balloon catheters in, but people that
Mhm.
don't want to learn how to do that technique, yet they have a large population of obese patients.
Yeah.
And I'm like, if you just put a catheter in that obese patient, you would have an idea of what level of PEEP they require. If you didn't do that time, I guarantee you will be called to that room every time they turn this patient, every
Yes.
time they had changed the bed sheets, like any time that they move this patient where they're clearly going to have some significant de-recruitment if they are under-peeped, like you're going to be in that room, standing there, probably bagging the patient,
Yeah.
bagging them up to get their set, like, doing everything we do to try to get someone's oxygenation back under control when really they just needed a PEEP level you were not comfortable with, but you didn't want to
Yeah.
put the time into putting in a catheter.
Yeah.
So I agree with you. Sometimes we argue that, we don't have the time, but then we don't realize how much time we're spending doing things that may have been avoided if we had used another tool that
Yeah.
maybe took a little bit time up front, but
Yep.
it figured the patient out to the point where you're not wasting any more time after that, right? So,
Exactly. So that's kind of how I try to sell it uh, uh, to some of the therapists, what that have that question, like, oh my gosh, when am I supposed to do this? I don't have any time. And just again, how many times are we sitting waiting around for chest X-ray to confirm what we think we already know? Like you use the
mhm.
example, I think they have a pneumo. Well, let's get chest X-ray up here to see. Well, I mean, gosh, if you put a probe on and you do an
Yeah.
assessment, you see, okay, there's no lung sliding over here. Or what? If you get real lucky, you find a lung point. Now you're really like, okay, there's a pneumo here. We can actually
Yep.
start to
I had a
treat.
patient, I was working in the ICU, this is 20 years ago, and this was 2006. I was working in an ICU, it was overnight, it was me, and it was a critical care fellow that was on in the unit. The staff was, like, on call, they could have called him in, but this fellow was actually great. Um, I was pretty sure my patient had a pneumo, like, I was positive they had a pneumo. We ordered an X-ray, but, like, and then this is before POCUS, like, people weren't talking about POCUS 20 years ago, like,
Yeah.
people weren't like, "Oh, let me grab the ultrasound to look for a pneumo." Like, this just wasn't the case 20 years ago. It may have started shortly after that, but, like, definitely this fellow, I wasn't thinking of it, the fellow wasn't. We ordered an X-ray, but she trusted me, and I trusted my own judgment so well that we literally had the patient prepped, like, ready, like, not completely prepped, but, like, everything in
Yeah.
the room ready to go. X-ray came in. As soon as we saw the X-ray, within 10 seconds, she had the chest tube in because, like,
Yeah.
she was, like, gowned up and just standing in the corner,
Yeah. Just
like,
waiting
totally
for the
sterile, just waiting
confirmation.
back, like, everything was ready to go because she was certain, I was certain. But if we had, back in the day, if this tool was available, you're right. We could have called the X-ray after we put it in if she really
Mhm.
wanted to. She could
Sure.
have been like, "There's definitely a pneumo here. Let's just get a tube in there. Let's then get a follow-up X-ray to see if it's resolved."
Yeah.
Yeah, it could have and again, X-ray was pretty fast. It was
Yeah.
2 in the morning, so they weren't, like, doing, like, every X-ray in the hospital, but that was a risk, right? Sometimes they might be busy and they might not get there quickly,
Yeah.
and now that we have these tools, it just seems like a no-brainer that someone should be trained to do that, and it makes sense that an RT should be trained how to do that for sure. Not that critical care fellows wouldn't be trained on how to do that now, but really, you think of the 2 people most responsible for making a decision with this patient in that moment, it's gonna be the RT and the physician on, like, that is covering that patient, so
Yeah, and to be honest with you, chest X-rays can be tricky, right? And I can probably pick out a pneumothorax on most chest X-rays of a patient that has a pneumo. But things like effusions aren't quite as straightforward because other things look like on the X-ray look like effusions, right? And so people
Exactly.
go back and forth. Is that an effusion? Is it not an effusion? And so in terms of just that one pathophysiology, I mean, ultrasound's got to be a lot better, and it is a lot
Yeah.
better than
Yeah.
waiting
I
for a
mean,
chest X-ray.
and that's actually one of the easier pathologies to see. I mean, you just hit
Yeah.
that, that posterior lateral section. I mean, you just see this big pocket of black, and you're just like,
Mhm.
oh, well,
mm.
there's
Yeah, yeah.
fluid, and it's a pretty easy thing to find when the
So,
patient has it.
so Tyler, what's your sense in terms of you mentioned this department in Texas?
Yeah.
And you guys, what's your sense for, like, how many is it catch is are more departments doing it?
Yeah. So Texas reached the department in Texas. I had a gentleman in New York called me again, just asking for research. They were starting the process of getting RTs more involved with ultrasound. So I sent him sort of all of my educational material and gave him some advice on how to get uh, their RTs trained. So I do think it's and I know there's some other institutions out there as well that have been utilizing it. So I think it's a growing thing, just like with all new technology. Although this isn't new technology, it's new in the hands of the RT. It'll just take some time to kind of catch on. I mean, it's still catching on slowly at our institution. So there's a few of the RTs that, you know, when I send my students over, they're like, oh yeah, so and so grabbed the ultrasound and we went and assessed the patients. The RTs use it all the time for vascular, all the time for
Yeah.
ABGs, and so that part, they're comfortable utilizing it for that. They're still just trying to figure out. They're always, their question is, when do I use it? When should I pull it out to use it? And I think, if you have a patient that's acutely decompensating, maybe you could take a quick peek to see if there's anything obvious. Obviously, you would need a lot of times you need a baseline assessment so you can see what changed, unless there was something acute that, like, for a fact they didn't have a pneumo before, and now all of a sudden they do. So there's that. And then I think things like assessing, maybe PEEP changes, again, if you don't have, I think EIT is, in time you use a lot of EIT. I know we're just starting to utilize that. And I think EIT,
Yeah, the main benefits is that you have you have a surrounded, in
yeah,
terms of EIT, it's taking a signal that's looking at the entirety of the chest rather than just, where your probe is sitting.
right. Yeah.
It is where the belt is sitting, but it represents a region.
Yeah.
But again, it's not it has more of a temporal resolution benefit than a spatial resolution, whereas like CT and ultrasound have a little bit more of a spatial. It's gonna be a little bit more. I mean, you can visually see things with an ultrasound. EIT,
Right.
you just see changes of volume going in and out,
Mhm.
right? Or
Exactly.
changes of impedance, which is translated as a change in volume. So you can't diagnose as well. Like a pneumo is pretty clear on EIT, but before throwing in a chest tube, I still would want to check with ultrasound because it could
Right.
just be that lung is not being ventilated for other reasons, and you
Yeah.
want to see that lung is inflated. Like EIT is not it shouldn't be right now a diagnostic tool
Diagnostic.
because the
Right.
spatial resolution is low, but temporal is very high. So that means distribution of ventilation is really well represented with EIT because the cycles per minute, it's like 50 cycles per second. So when you think, I meant per second, not per minute, but
Yeah.
yeah, so 50 cycles per second is a huge temporal resolution. Like you can see movement in real time very accurately, but yeah, the spatial resolution is missing.
Yeah. And, like when I think about looking at overdistension, when we're doing PEEP titration, EIT does pretty well at determining, okay, there's some overdistension here.
Yeah, because it'll tell you a compliance change. Whereas with
Exactly.
ultrasound, it's just going to look well aerated,
It's going to look
essentially,
well
right?
aerated. Now, there is a study, I can't remember when it came out, that looked at ultrasound and EIT and looking at, over distension. When you're looking at ultrasound, you should see your visceral and parietal pleura sliding along
Mhm.
itself. And what they
It
found
likely
was
would
that
slow down a bit if it's
but the
overdistended, right?
movement
Mhm.
slowed a lot when the patient was starting to become
Mhm.
overdistended.
Yeah,
And
makes
that
sense.
correlated with the findings on EIT. Now, again, that takes a very nuanced, like, gosh, is that lung slowing down? Or, so a little nuance
Yeah,
there.
and then
Again, there's
understanding what's normal
methodology.
lungs, like
It's a
what's
little
Yeah.
exactly
subjective. Yeah.
Yeah. It's
normal
subjective.
lung sliding distance
Yeah.
versus slowed down.
But,
Yeah, it gets a little bit
but that being
complicated,
said,
but
there's the time. And again, there's software on some devices that will actually quantify the movement for you.
mhm.
Um, in various modes that you apply. But again, I think there's opportunity. It's just another
Oh,
tool,
I've heard through the rumor mill that somebody's working on an ultrasound vest.
an ultrasound vest. So it's just like
Yeah,
constantly
just
ultrasounding,
probes
probes
everywhere.
Probes
everywhere.
everywhere, huh?
Yeah,
Just when you thought you
yeah,
couldn't
yeah.
put a probe any other
Yeah, it's
place.
like, "Oh, I can only see one spot at a time." It's
Yeah.
like,
Now
"Hold
you
my beer,
see.
put
Yeah.
put this vest on the patient, and we're gonna ultrasound
Oh,
in
that's
every
pretty
spot."
cool. A
Yeah.
lot
Wow.
of ultrasound gel just lathered over the patient.
Lathered
Yeah,
up.
because I have a good friend and colleague who's actually coming on the podcast, Dr. Alberto Golfi. He's a huge fan of POCUS, and, I think he's the one that mentioned that, like, they're considering, like, whether it's a belt or a vest, essentially, it was like a multi-probe device that could, like, analyze various regions at one
Yeah.
time that, like, clearly it's in like research phase. Like
Yeah.
he didn't even mention a company. He's just said that like people are working on this is all he said. And
Yeah.
I'm just like, well, that's interesting. I said, that doesn't seem like it's going to be it seems like it's going to be a very, it's with the technology we have now, it seems like it would be a very heavy device, because if
Yeah.
you think about the probes aren't like minuscule now. Like they're
Right.
not like like EIT, you can put stickers on a chest.
Exactly. Yeah.
With a lung ultrasound probe, you've got some bulk there for
Seems
sure.
like it would be uncomfortable to lay on.
Yeah,
unless
by
just-
themselves,
Yeah,
they're not heavy, but if you have a bunch of them,
Yeah.
then it certainly
That's
would.
interesting.
Let me
Yeah.
interject with this.
Yeah.
Just a story. I like to sort of bring things home to it, to an example. I won't say where this place was, but recently, the interventional radiology team that is sort of mobile. In other words, if you need something done via IR, but your patient might not be stable enough to go, then they'll come to the bedside, they'll put chest tubes in, and they'll do things. They were called to see a patient to put a chest tube into what appeared to be on the X-ray on a regular portable chest X-ray to be a huge effusion.
Mm-hmm.
So they came to the bedside. This patient was a spinal cord injured patient, and they put a ultrasound probe on like they would do any time before they were going to put a chest tube in, and realized that there was no fluid in the pleural space, that there was a huge plug of the whole right side of the chest.
Yeah.
And so they, of course, wound up not putting a chest tube in, and then the RT team had to do did a bronchoscopy and did a bunch of interventions. But I see, so so if somebody had come to just put a chest tube in that patient and had just put the chest tube in based on what somebody else. Now, when you go back and look at the chest film of this patient, you could see basic RT 101 where a volume loss causes a tracheal shift towards it, and a volume gain, which would have been an effusion, would push the trachea to the other side. So this should have been picked up before it actually was, but thankfully it was picked up before a hole was put in the patient's chest.
Yeah. I mean,
But just an example of how ultrasound sort of saved the day for this particular patient.
And it's probably relatively quick. Hence why they're like, let's do this just real quick before we proceed. Yeah. I mean, anytime you follow a physician around and they're doing a thoracentesis, they know there's an effusion there, but they're grabbing the ultrasound, finding the spot that they want to, where they want to, to insert the needle.
I remember a story of someone seeing a chest X-ray and they thought it was a large effusion and did not follow up with ultrasound. And then the resident put the chest tube in, and turns out they had a
big liver.
They had a big liver and a paralyzed hemidiaphragm. So it actually wasn't effusion, and they just proceeded to put a chest tube into the liver. That patient.
Yeah, I knew where you're going with that, because I've seen that
patient
happen
went. Have you? Yeah, this is not apparently not as uncommon. Whenever I
the
tell
liver
this story,
does
someone's
not
like,
it when you put a chest tube in it.
No, it does
By the
not. This patient was like straight to ICU for you from the emergency room.
Straight to the operating room, probably.
Yeah, I think they ended up going there, but like clearly, I feel like something like ultrasound would have really been able to distinguish liver from effusion, because the liver looks quite different than the average of effusion on ultrasound. But on the X-ray, it looked, it just looked like a big whiteout. And it's like, oh, that must, and of course the diaphragm's up here. So they're like, oh, that whiteout must be effusion. Meanwhile, there was actually a diaphragm there, and that was just liver sitting higher than normal. So they put a tube in it. It didn't fix the effusion that wasn't there, but they did get blood. They did get blood back in the tube. Unfortunately, it was not the blood that they wanted. Yeah.
Well, it's not a hemothorax.
No.
Right?
No.
Wow.
No.
It's unfortunate.
Yep. I'm glad to hear that you said that you've seen that happen.
Yeah, I have seen it.
I feel like you're not the first person to say that that's happened when I've told that story, but it's unfortunate, but I feel like we've come a long way. I feel like no person would put in a chest tube in a patient like that without ultrasound now. Like I feel like focus has gotten to the point now where, particularly in the emergency department, where you're not going to make these decisions without using ultrasound. I don't know if any of you guys watch the show The Pit.
I
Great,
haven't, but I've heard
great.
good
It's
things.
fantastic.
Yeah.
They're on their second season now, and like there's a lot of POCUS in that. Like it's actually being praised for a lot of its accuracy. The only thing that drives me crazy is that they don't call for RT enough. Like there's
Yeah.
a lot of airway emergencies. There's a lot of stuff related
Yeah,
to
at first they
airways.
never did. The first season, I feel like they
once in a
never
while
did.
like so I think 2 episodes ago they're like, can someone call RT? And I was like, finally.
Yes.
We figured out
Yes.
who the RT is. Like they're not a main character. Like we don't know their name, but
Yeah.
my partner and I, who is also an RT, we can recognize. We know who the RT is on the show now. Like they have a dedicated actress that is an RT.
They got
but
one.
They just don't. They just don't verbally say, "Can we?" They're like putting a tube into it's like a wound, and they're like holding a trachea with. Basically with like just holding it there with clamps, and they're like, no mention of RT. I'm like, I'm pretty sure we would be right there trying helping out with this in any way. In one episode they cut an endotracheal tube in one episode, and it was the doctor doing it, and we're like, they're pretty sure they would just hand us the RT and say, cut this tube for me. But anyways, I digress.
I remember last time I cut an ET tube. We used to do it quite often, but
well, this was one that they were putting it right directly in a neck, so they just wanted it shorter. But anyways, they my whole point was they actually perform a lot of POCUS, which I think a lot of the stuff on that show has been positively criticized as being relatively accurate in terms of like what actually goes on in an emergency room when shit's hitting the fan. Obviously, like and for those who don't know, if you haven't watched the show, it takes place on one day. So this season happens to be July 4th weekend. And of course,
that's
for all of us that have worked in a hospital on any long weekend where there's parties and celebrations and fireworks, you're gonna have a busy emergency department.
Yeah, I'm sure you guys like me have had days that seem like it was a whole season. Right?
Yeah. Oh,
yeah. It lasted for a whole season.
Yeah, and the whole season is one day. So like every episode is an hour in a shift. It's like a 12-hour shift, and each episode is 1 hour.
Wow.
So it's like as the day goes on, you're like, this is the same day, and it's just like, yeah, we've all seen days like
all
this.
had those days.
Well, again, it's a little bit crazy, like cyber attacks and stuff like that. But anyways, it's a good show. I highly recommend for those who haven't watched it. Yeah. Cool. But they could represent RTs a bit more for sure.
Yeah, we need to get a show to have a main character. He's a main character.
Yeah. Yeah, they've got a number of nurses as main characters.
Like a love interest or something. That's usually how it spins the drama.
Yeah.
Madison and I would be sitting watching TV and just be not the Pit, but other shows, and just be, gosh, they couldn't afford just to have some sort of technical advisor or something that would tell them this is completely wrong. I do the same thing. I was in the Marine Corps for a long time, and I do the same thing when I watch a movie that's got Marines in it, and I'm like, oh my God, they could have got somebody just to say that's not where that ribbon goes, or that's not how they salute, or that something. Man, discouraging. So we digress just a little tiny bit, but
that's all right.
But that's okay. Yeah, Tyler. Well, we really appreciate you coming on today, man. And
it's been fun. Yeah,
I guess we could go on and on and on about this, but we won't. We'll have you back though at some point in time.
Sounds good. Yeah, I love what you guys are doing. So
you'll have us.
Please keep it up.
Thank you.
Appreciate it.
And maybe we'll get a starring role one day. And
yeah. Who knows?
We just need to get the word out that we exist.
Yeah.
Yeah.
Well, Dr. Weiss, we appreciate you sharing your incredible insight and expertise, and thanks to the listeners for joining us and watching this. And we put a teaser out every Friday for Monday's new episode, and so be on the lookout for that. Again, you can go to www.inspire-rt.com, and we have links to all of our podcast episodes, panel discussions, other resources, et cetera, et cetera. So be on the lookout for those things. All righty, gentlemen. Thank you so much. You guys have a good rest of your day, and we'll talk to you soon.
Thank you.